for me to be the only non-American speaking here. There are two wrong reasons I'm here. First of all, I'm not a neurologist. I'm a critical care physician treating patients with trauma or acute neurological dramatic situations or with septic shock. And you will see that those patients with shock has learned us a little bit about the mechanism in transverse myelitis or acute demyelination. The second thing is I'm from Belgium, and when I drove in with the taxi from the airport to the hotel, the taxi driver asked, where coming from? Well, I said, I'm coming from Belgium. He said, well, you have great tennis players, right? At Roland Garros and Wimbledon. I said, well, it's a little bit a pity we lost from Capriati and Williams just in the final. So there are four important reasons why Belgium is so famous. First of all is the tennis, but that's since 3 weeks actually, okay? The second thing is Belgian chocolates, which you eat regularly, okay? The third reason is the Tour de France, which we won always in the 50s, 60s, and 70s, until in the 90s there was somebody called Armstrong, which was a little bit more powerful. And the fourth reason is that there is a multiple sclerosis center in Belgium where they do the first vaccination study against recurrent attacks in multiple sclerosis. Now, 10 years ago it started a little bit. And this is actually also the basis of my talk of today, because we used much of the technology that was developed in that center for patients with MS. Now, the goals of my talk are, first, to describe what might happen in acute demyelination, the interaction between antigen, a foreign thing which enters the body, and define what the superantigen is. To describe a reaction caused by streptococcal exotoxins in acute demyelination, to look if there are any clues in epidemiological studies why superantigen might play a role, and to look if some of the therapeutic options which are used today might be linked to this cause. Now, as you heard from many previous speakers, acute demyelination is an inflammatory reaction with the infiltration of inflammatory cells, especially around the vascular structures, T lymphocytes and macrophages, and the local synthesis of inflammatory mediators, as you heard from the previous speaker, a very profound inflammatory reaction. Now, there are two important theories to support this inflammatory reaction. The first one is there might be a direct invasion of a virus, for instance, like you see in poliomyelitis, but this is only a very limited cases of myelopathy, as you heard from the previous speakers. And the second main theory is that it is an autoimmune reaction. Viral or bacterial agents, or whatever it might be, might play a role in the activation of those autoreactive. Autoreactive means reactive against your own body T-cells. For that to occur, there is a migration of T-cells into the central nervous system, as shown by the previous speaker so beautifully. And those cells can only cross the blood-brain barrier, can only enter the central nervous system when they are activated, when they are brought up to a higher level. And then once they come into contact with the myelin of the nervous system, they become reactivated and they start an autoimmune attack against the nervous system. Now, that autoimmune attack, that autoimmune process is mediated, as said, by autoreactive T lymphocytes, which might react with a certain specificity against several compounds of myelin, because myelin is not one compound. You have the myelin basic protein, which is a very important one, but the last years we have learned a lot that there are many proteins actually called also proteolipid proteins and very different names. Now, there are some problems if we adhere to this theory. The first one is autoimmune T-cells directed against various myelin antigens can be isolated from most individuals walking around here in Baltimore. However, the problem is, in most individuals, they do not lead to an autoimmune mechanism. Either they are energized, which means they are in a low state, they are not activated, or they are present in low numbers, but they are present. They are present in almost every person walking around. The answer to that is that in the periphery, in the peripheral blood of patients with multiple sclerosis, a same amount of those, or a comparable amount of those autoimmune myelin-specific cells are present, capable of attacking the myelin surrounding the nerves, but that they aren't in an energized state, they are activated. They are responsive to IL-2, and IL-2 is an important inflammatory mediator which also plays a role in, for instance, transplantation medicine. So the main difference is they are there, but they are activated. They are ready to attack. The second problem is, how for sake are those pathogenic autoreactive T cells activated, as when they are circulating in the peripheral blood, there is no direct contact with the central nervous system. There is no contact with the myelin. They are just circulating in the blood. Now for that there are two important theories. One already mentioned yesterday, which is called molecular mimicry, which means that a specific peptide or other part of an infecting agent, a virus or a bacteria, shares a sequence homology, has the same compounds, is almost identical to certain parts of the myelin. If you put them together, if you put the amino acid sequence, for instance, of that part of myelin together with the amino acid sequence of certain parts of viruses and bacteria, they are almost identical, which means they are exchangeable at least. For instance, as you heard yesterday in studies with Guillain-Barré syndrome, it has been shown, and there's a beautiful study showing that many of the agents which can cause acute demyelination, whether is it transverse myelitis or not, such as herpes, such as abivirus, such as adenoviruses, certain bacteria we see in ventilated patients, they all have a sequence homology which is identical to certain parts of the human myelin. Now this is not the only answer, because many people have contact with those different viruses and bacteria, and they don't get transverse myelitis or they don't get demyelination. So autoactive reactive T-cells activated by this molecular mimicry leads only to autoimmunity in a very minority of sensitized individuals. So this is not the only answer. The second mechanism might be related to a very beautiful but dramatic word called superantigen. And myelin reactive T cells from normal individuals and from people with MS can be activated in vitro by so-called superantigens in an unconventional manner. And once they are activated, they can cross the blood-brain barrier, go into the central nervous system, and react with myelin. Now I'm going to define you what superantigen really means. And in a country where the Super Bowl is so important, that should be something to do. Now, in a normal antigen reaction, in a normal reaction when you consider something as strange, you have what they call an antigen-presenting cell. It's a cell which will present the antigen to the lymphocyte. Those are dendritic cells, B cells, and macrophages. Okay? And they activate these C cells, they process the antigen, they present it to the T lymphocyte by processing it, and by displaying it on their surfaces together with some other antigens called the MHC2 antigens, and those are antigens which play also a very important role in transplantation medicine. And once this antigen is presented to the T lymphocyte, that cell which is going to cause the damage to the myelin, it's very important to know that the receptors responsible for that, the T cell receptors, are two different ones, with different names, and there is only one type of receptor, alpha, beta, or delta. There's only one type of receptor for every specific interactions. And that receptor, and it's going to be even more difficult than I taught you before, has two different regions, a constant region, which is always constant, and a variable region which might change according to the exposition to the antigen that has been presented. So in a normal reaction, protein antigens are processed, they are brought into the cells, they are broken down to small peptides, then they are associated with MHC, with those antigenic determinants playing a role in transplantation medicine. They go up to the surface of that cell, then they are sampled by T cells with a unique T cell receptor, only one type for a particular antigen complex. And then when that bindings takes place between the cell that presents the antigen and the T lymphocytes, you have a CDR3 hypervariable region, which is a region adjacent to that T cell receptor, which is also very specific, which recognize it and which we can use as determinants for recognition with a high degree of specificity, and that's necessary for single transduction so that the inflammatory reaction can go on. Now this is a very difficult talk, but I'm going to try to summarize it again. You have, for instance, a bacterium or a virus, an antigen, something strange coming into the body. It's taken up by the antigen presenting cell. It's broken down into small peptides. It's combined with those antigens playing a role in transplantation medicine. It's transported up to the cell membrane, and there, in a very peculiar manner, it reacts with the T lymphocytes by a T-cell receptor, where this broken down antigen is combined with those MHC2 class antigens, as they call. This is what happens normally when you get urticaria, when you get asthma, when you get whatever it is as an antigen antibody or an antigen reaction with T lymphocytes. Now, superantigens work totally different. There are a group of microbial proteins that can be produced by viruses, bacteria, and by mycoplasma, and they interact with the immune system not on this very peculiar manner, but in a very unconventional manner. The first thing is they are bifunctional molecules. They bind to two functions, to two cells directly. They utilize two receptors expressed on different cells of the immune system. On T cells, they use that specific receptor, and they are capable of binding to that variable region which we call V-beta of the T-cell receptor in a characteristic set, actually, which means that if you look into the blood and you do a synthesis of those T-cell receptors, and you find those very variable regions which you can determine back, you say, well, the person or the animal has been exposed to that peculiar case of antigen, let's call it superantigen. And they bind on the other side, they bind to the antigen presenting cell by MHC class 2 molecules. You remember it had to be processed, the normal antigen, to the cell wall. And first they bind to that and then to the T-cell receptor. Once they bind to this T-cell receptor, to this T-cell, they trigger a lot of intracellular biochemical signals that causes activation, differentiation of the cell, proliferation. They divide, they get more T lymphocytes, and the release of many inflammatory cytokines. And this is unique because they don't have to be processed by the antigen presenting cell. They don't have to be broken down, so it goes quick. It's more unique even because they interact not only with one specific cell, as you see in a normal antigen reaction, they interact with a large number of T cells which share that particular sequence in that variable region known as the V-beta elements. And once such a superantigen enters the body, either in a mammalian or either in the human body, you find up to 5 to 20% of certain T lymphocytes who can react immediately with its superantigen. So this is what happens with a normal antigen. You have a very low percentage of cell responding. You see this expressing in percent, a high amount of cells responding superantigen. They're all dependent on MHC2, those antigens related to transplantation medicine, but they don't use those variable regions in a restricted manner. The normal antigens, the superantigen does. So the three criteria for a superantigen that might correlate in demyelination is there is a reproducible pattern of selective interaction of that variable region. So if you stimulate T cells with a given toxin, that leads to a selective expansion to a selective marker on the T cells, which we can use as a proof that there has been this exposure. Secondly, it's dependent on the MHC2 class molecules. Okay, very specific interactions. And three, and that's the big difference, there's a lack of requirement for complex processing by the antigen presenting cell. It hasn't to be broken down. It goes quick and in an enormous quick way. Moreover, those antigens, superantigens, can activate many of the different subtypes of T cells, which would lead us too much. and they can cause apoptosis, which means cell death. If you need funding in Europe nowadays for whatever it is in scientific research, you have to put one word in it, and that's a magic word, which is apoptosis, which is programmed cell death. And if you put in that there, you get money, because the last 2 or 3 years, everybody believes that that is an important physiopathological pathways in immunological reactions. And this is again a presentation. So you have the T lymphocyte, you have the antigen presenting cell, and instead of being processed, it binds to the 2 receptors and then activates other binding molecules in a very specific way. So it has not to enter this cell and then go up here. It just brings the 2 cells in a very quick way together. Now, what are superantigens in our daily life? They are called what we say pyrogenic exotoxins. Pyrogenics because they can cause fever. Exotoxins because they are excreted by the different microbiological agents. And the most important bacteria which it causes is Staphylococcus aureus, which is called enterotoxins, a lot of toxics. Enterotoxin is a substance that causes fluid secretion in the intestine in animals, and therefore cold. The other one is the Streptococcus pyogenes, the meat-eating killing bacteria, as they are called in the literature. Group I, Streptococci, which are called exotoxins, and Mycoplasma, another microbial agent, might produce those superantigens. Many other bacteria and infectious agents can produce such compounds. Pseudomonas aeruginosa, a bacteria which we see in ventilated patients. Yersinia, which causes diarrhea. Clostridium, which is actually a microbe which doesn't love the air. Other streptococcal, but also many viruses are capable of releasing this specific type of antigens, herpes virus, HIV, rabies, as you heard, and so on. They interact so with a large number of T cells. They elicit a very strong inflammatory response. 5 to 20% of the T lymphocytes get activated at once. They enhance their susceptibility to shock, and that's the reason why we know it in the critical care, as a critical care physician. There exists something like toxic shock syndrome, which is a very profound shock after exposure in certain individuals to Staphylococcus or Streptococcus, and many of the patients die because we don't have a very good treatment for that unless treating shock. And they are globular proteins which have a little bit of structural feature among the different microbial agents that can produce it. And moreover, every month there are new data on new types of superantigens which might react with T cells in very different ways. Either they may activate or proliferate it. If there is no stimulation in you and me, all our T cells are in energy. They are paralyzed as a T lymphocytes. They don't react. And if there are excessive inflammatory mediators around, they get apoptosis. The cells die. Now, why should we look at superantigens in acute demyelination? Is there any proof of that? Well, in adult patients with multiple sclerosis, that specific usage of that variable part of the T cell receptor has been proven. If you look into the brain or in myelin reactive T cells in the peripheral blood of multiple sclerosis patients, you find selective regions of that T cell receptor which have been activated in the past, which might be not a proof, but at least an indication that those patients in the past have been exposed to superantigens with a very specific activation of a very specific part of the T cell receptor. And when you look to the experimental counterparts of our acute demyelination, then we know that superantigens, part of streptococci and staphylococci, when they are injected intraperitoneally, for instance, in those animals, can cause reactivation of encephalomyelitis, which you heard yesterday is an experimental model, experimental allergic encephalomyelitis for acute demyelination. And those encephalomyelitis in those animals, in those rats, cause a selective expansion of those T cell receptors in a very specific way, at very specific variable region, which is comparable to what you might see in humans. So the question until now was, does it really play a role in humans? Because we have compelling indirect evidence from animals and from brain biopsies in multiple sclerosis patients, but we were we are missing the real link, the real proof that in a patient, in vivo, this plays a role. So we had the fortunate and unfortunate opportunity to study a 3-year-old child which has a history of recurrent otitis, actually, with normal developmental milestones and, as opposed to the previous speakers, no previous vaccination. It presented after a vacation period with lethargy, with vomiting, with a sort of meningeal syndrome, and with otitis there was really pus coming out of the ears. The patient was cyanotic, hypotonic, had an anisocoria, had a pupil on one side which was bigger, which was greater than the other side, and needed in the other hospital to be intubated due to respiratory insufficiency. A CT scan showed a lesion in the right temporal region, and it was transferred to the University Hospital of Antwerp, where I'm working. Now, in our emergency department, we saw a tetraplegic, quadriplegic child with an anisocoria and with a purulent discharge from both ears, actually. The biochemistry was normal. There was a polyclonal increase of some immunoglobulins, and there were some slightly decreased lymphocytes present. Toxicological screening, you remember toxicological agents might be responsible for acute syndromes like that, was negative, and immunological screening was negative, and organic acids looking for any inborn errors of metabolisms were negative. And 2 consecutive lumbar punctures with 2 days in between show, well, actually very little white blood cells, a little bit increased, a total protein that was 81 milligram of deciliter, a little bit increased but not enormous, an increased gamma fraction, and no malignant cells were present. All cultures which we did, because the patient also presented with a fever of 40 degrees, of blood, of nasopharynx and so on, were negative. And from the middle ears, we cultured on both sides Streptococcus pyogenes type M6, and I will discuss this later on. We cultured one of those bacteria which, from a theoretical point of view, can cause superantigen-mediated acute demyelination. There was a culture of the cerebrospinal fluid which was negative. There were many viral cultures done which were negative, including PCR, okay, as you heard yesterday, as being an important tool to see later on, and there were actually no tools for any known microbial agent to cause something like that. There were no raised antibody titers for 28 different agents. I know it's a little bit exaggerated, but we worked out the case very profoundly, from adeno to toxoplasma, that's just because that's the start of our alphabet and that's the end of it, okay? No other reasons for it. Is that an HLA DR3, DR2? Remember what was said yesterday. This is one of the hallmarks you might find in some patients with multiple sclerosis, okay? And we did an MRI once the patient arrived because we thought it was a kind of encephalitis actually thing. And what we see on the T2 weighted images were multiple scattered and confluent areas in the subcortical and diaphragmatic matter, asymmetric, ranging up to 20 millimeters in some regions, and with a large, unfortunately large region in the lower medulla oblongata, in the brainstem, and in the cervical spinal cord, which we considered as confluent areas of demyelination or acute inflammation, and which is shown in the last one. Here you see only one of those lesions, okay, in the brain, and this is the enormous lesion you see here, coming up from the medulla oblongata, from the brainstem, and all going down up to the cervical spinal cord. Now the electromyogram was normal. There were no peripheral lesions, and the evoked potential showed delayed latencies, and later on there was no transmission anymore from the brainstem actually to the periphery. At that time we thought, well, when everything was, let us treat the patient like we should treat every patient with an encephalitis in our protocol, which is acyclovir for herpes, erythromycin for mycoplasma, because we have a few mycoplasma-related encephalitis had in our institution, and other antibiotics. But soon we switched, after the cultures were negative and thinking about the autoimmune process, to corticosteroids and immune globulins. And I want to emphasize that this is not a standard therapy, which should be emphasized, but it's in Europe more readily accepted and paid back in this kind of situation. So we could use it instead of other situations, and we used immunoglobulins for 5 days. And we did that actually for 5 different monthly courses, and the patient had different cardiovascular problems. Now, 35 days after admission, what you see here is you have the spinal cord here, and that breakdown, that very intense lesion has gone away. But the most dramatic part of it is that if we take out follow-up MRIs and the patient remained dependent on the ventilator and remained tetraplegic, that there is a complete atrophy of the lower part of the brainstem up to C4, okay? Which explains why he remained tetraplegic and dependent on the ventilator, because all the muscles which are regulated, either the diaphragm or the intercostal muscles, weren't innervated anymore, and the patient was, of course, tetraplegic because there was no actually signal going on to the central nervous system anymore. 6 months after admission, knowing that he has been exposed to this streptococcal thing, we went to the Netherlands, where they actually determined the titers to antibodies to superantigens, and we found very high titers to superantigens of this Streptococcus pyogenes, indicating at least indirectly that there has been this exposure, and the patient remained tetraplegic and ventilator dependent. He received a tracheostomy, a portacat catheter, a suprapubic urinary catheter. You can discuss about that if there is any other treatment, but it was a very difficult ethical discussion with the parents and so on. An enterogastrostomy to be fed, and the only thing the patient could do was the expression of its facial musculature has been improving. He learned to eat and he learned to speak actually by the air which came not through the tracheostomy but from the surroundings. This was a very important ethical discussion actually, and this was a very dramatic case. He has been hospitalized for 2 years in our intensive care unit. We made a special contribution to that. He went to Disneyland in Paris with 2 doctors and 2 nurses of our service. Okay. So, and he returned home after 30 months of hospitalization. Okay. And then died 6 months later due to 41.5 degrees Celsius temperature with generalized convulsions, with new lesions on the MRI, new scattered lesions, okay, and due to an increasing cerebral edema, and he died. Now, the hypothesis in this very dramatic case of acute demyelination was in vivo exposure to streptococcal exotoxins, to superantigens in this child, may have induced the activation of myelin reactive T-cells, not causing, but contributing to this dramatic inflammatory demyelination. So the first thing is what we wanted to prove is this particular Streptococcus pyogenes coming from this ear is a microbe capable of producing superantigens. And we did a genotyping methods, and indeed it produces 4 different very powerful superantigens which are believed to play a role in toxic shock. And they are called A, B, C, and F. So the first conclusion is this type of Streptococcus pyogenes, this type of superantigen producing bacteria produced in this patient different superantigens. The second thing is we wanted to do is to characterize the peripheral blood mononuclear cell, let's say the T lymphocytes which were present in those patients, which we do with a special technique. And what we saw that there was an increased percentage of CD3 T cells. Okay? And the hypothesis is that in vivo activation by superantigens will lead to expansion of T cells in a very specific manner. You remember, very specific activation of the variable part of the T cell, inducing sequence what we do, and we did that with a semi-quantitative PCR ELISA. And indeed, in this population of the T lymphocytes which we get out from the patient after a few weeks after the acute attack, we saw that there were specific regions called, this doesn't matter, 4, 7, and 14 which were overexpressed. And if you look to the literature, this is very strange. If you submit T lymphocytes, if you submit inflammatory cells in vitro with the streptococcal exotoxins which were isolated by in our patient from these Streptococcus pyogenes, there is an expansion of 4, 7, and 14 of those different genes. And if we put out the Streptococcus pyogenes, cultured out a supernatant, and put it again with T lymphocytes, you also see a very specific activation also of 4 of very specific regions of this T-cell receptor. So the second conclusion is a restricted number of genes, a restricted number of the T-cell receptor genes, so specific for expansion, okay, were expanded in this patient, and at least some of the expansion were caused by superantigens released by this Streptococcus pyogenes strain. And then we said, well, now we've proven that there has been an exposure to superantigen and to this bacteria. We've cultured this bacteria from the ear. Has this bacteria caused an attack against myelin? So, in the Multiple Sclerosis Institute, they isolate MBP reactive T-cells, and as I told you, they are circulating in every patient, comparable whether it's a multiple sclerosis or a healthy subject, you find those cells. But the difference is we found cell lines, we cloned them, okay? We divided them from a same ancestor, okay? And 4 of them at a totally identical amino acid sequence, which means that the T cells in this patient in the peripheral blood, okay, were clonally expanded. We're all coming from the same T lymphocytes which had been activated by a superantigen, whatever it is, weeks ago, and then started to proliferate and started one after another to divide. And this is the hallmark of what happens in acute demyelination. You find MBP reactive T cells, but they haven't been clonally expanded. They're just swimming around, but they haven't been proliferated, they haven't been activated. And this was the case in our patients. So clonal expansion with identical sequences, which would lead us too far, is the hallmark of in vivo activation. Then we said, well, if we have now those MBP reactive T cells, if we know that they are capable of attacking the myelin in this patient, okay, can we also prove that they attacked really the myelin? So we took 4 of the 11 lines and we cultured it together with the supernatant of this bacteria, which we kept for many months. And we looked to what we call thymidine uptake, let's say the proliferative activity, the activity of activation and proliferation. And if we use that supernatant of that bacteria and not of many other bacteria which we cultured in the lab, there was proliferation, there was activation. And all the tested clones not only were activated by the supernatant, by this bacteria, but also by the different exotoxins which we got all over the world where they were isolated. So, the expansion, the enormous proliferation of T cells reactive against myelin might have been caused by an interaction with toxins produced by this isolated Streptococcus pyogenes strain. And then we went as a last thing to see, well, if there was such an important inflammatory reaction, and as you're going to hear later on this morning, if there are so many cytokines and interleukins and inflammatory mediators activated, is this also true? Yes. In our patient, in the peripheral blood mononuclear cells in the lymphocytes, there were enormous increases of IL-4 and IL-2, which are anti-inflammatory agents which our body produces as a kind of defense once an inflammatory reaction takes place. They call it the Th2 biots because there are 2 subsets of lymphocytes, Th1 and Th2. Th1 produces inflammatory cytokines, Th2 produces anti-inflammatory cytokines. And after stimulation with the Streptococcus pyogenes, they even could get much higher, which means that they still had the potential to cause more damage. So conclusion 2, such an inflammatory profile of such a particular production of those cytokines has been found in patients, other patients with encephalomyelitis, and the shift of an inflammatory to an anti-inflammatory state has been found in experimental allergic encephalitis. And moreover, if you treat a patient with glucocorticoids, which we did in our case and which will be the case in many patients with transverse myelitis, you give them a clue to act anti-inflammatory and you shift your T lymphocytes from being inflammatory to anti-inflammatory. And this might also be a little bit an explanation why we observe this. So the general conclusion from this one patient is human T-cells showing in vitro reactivity to myelin antigens might be pathogenic in vivo. And I don't want to proclaim first authorship or whatever this is. I think this is the first proof of an in vivo exposure to superantigens, to certain bacteria, to an alternative way of acute demyelination which causes, or which have contributed, not causes, I may be very careful, which might have contributed to the acute demyelination. Okay. We think it was not a classical case of transverse myelitis, but encephalomyelitis, because it was at young age, presenting with fever and aphereflexia, and with many multifocal lesions, not only in the cervical spinal cord, but also all over the brain. Do we have any clues in many other patients with acute demyelination that superantigens play a role? Well, for instance, if you look to meningoencephalitis or encephalomyelitis, all kind of names are used together actually to aid them. There are 3 cases of, among many other cases of other viral and bacterial agents, 3 cases of previous exposure to Streptococcus pyogenes. In transverse myelitis, I only pointed out Mycoplasma, but you may add tens of viral and bacterial agents which can produce superantigens, which have been linked to transverse myelitis. This is only one paper showing that bacterial infection actually, and in this case there were many patients with pharyngitis, which might be caused by some of the streptococcal species, might play a role in exacerbation of multiple sclerosis. I'm not a neurologist, I'm just pointing it out that there are some limited epidemiological clues. And if you look to the many causes of encephalomyelitis and demyelinization, many of the causative agents, whether it is herpes, Epstein-Barr virus, Streptococcus pneumoniae, Streptococcus pyogenes, and so on, they all have the capability of not having a normal antigen reaction, but it's a so-called superantigen reaction. Don't worry, nobody's going to do these kind of tests which we did with any of you again. It took a PhD and another person 1.5 years in the lab to clone the 11 different MBP selective T-cell lines. So this is not the basic research you're going to look for in the coming years. It's just unraveling one of the important or eventually important mechanisms. There's a strange thing. The patient presented with an otitis. Okay? Now, there are some animal models in gerbils where the inoculation on the ear in France with Streptococcus pneumonia and Listeria monocytogenes, I saw when we started here the pictures of Paris in front of us. Well, the reason why they do that in Paris is because they have a lot of problems with Listeria and the cheese actually in France for the moment. So, and if they have inoculation in the ear, there's a meningeal invasion, and then you have encephalitis. Don't say, please, that Philippe Jorens has told you that otitis is causing encephalitis. It's not. It's just showing that otitis or inoculation in the ear might be one of the many different ways why a microbial agent might enter the central nervous system. So, superantigens causes demyelination and or contributes to demyelination and causes a very important atrophy of the cervical spine in this case. Now, just to end, what are possible therapeutic strategies in patients with superantigen-related demyelination? As a critical care physician, we know that if you administer antibiotics to a patient with a toxic shock caused by Streptococcus or Staphylococcus, it doesn't help. Okay? It doesn't work. I mean, once the acute manifestations are triggered, they are ineffective. You have to give them to kill the bacteria, but they are ineffective to stop the autoimmune or the immune mechanism. Anti-cytokine therapies, if there are so many inflammatory mediators, well, I participated as a principal investigator in many trials in trying to block out cytokines in sepsis and septic shock. It's beautiful, but it doesn't work so well every time. Should we vaccinate? Instead of saying not giving a vaccination, should we vaccinate just as we have tried in multiple sclerosis patients? we don't know what that means. Okay, so to try to block this superantigen theory, and this is not going to help the patient with acute transverse myelitis, because once you have the vaccine, you're weeks and months later on. We are used in Europe to use immunoglobulins more regularly than you use in the United States. And why do we do that? Because they are known to modulate cytokine release and production by T cells and B cells, and they decrease IL-2, or you remembered IL-2 responsive cells in MS. They decrease production of many cytokines. They modulate the function of many lymphocytes. They inhibit antibody production and so on. And they contain neutralizing antibody, not alone against cytokines, but also to superantigens. Okay? There are a mix-up of immunoglobulins of many thousands of patients coming all over, okay, plasma, and then some of them are inhibitory to superantigens. They contain those HLA molecules, so they might competitively inhibit the binding of superantigens, and they contain antibodies to very specific sites of the T-cell receptor, that specific consumption that has been taken place. And if you use glucocorticoids, did you ever think that both endogenous and exogenous glucocorticoids or corticosteroids regulate the T-cell responses to superantigens, and they can inhibit the superantigen-mediated deletion, apoptosis, of mature T lymphocytes? And did you ever think, when we use corticosteroids in intensive care, we do that as a dose of 1 or 2 or 3 milligrams per kilogram, and the only way when we use 30 milligrams per kilogram is when there is spinal cord injury, when there is damage to the central nervous system. Well, a superantigen, I do not want to proclaim that this is the mechanism, but the superantigen induces glucocorticoid insensitivity. It increases the amount of glucocorticoid receptors, so you need more, okay, to have the same effect or to have the same therapeutic action. I just want to end with a philosophic view. Why do bacteria produce superantigens? Well, they want to render the host immunocompromised in preparation for takeover of an organism, as we see in cases of superantigen-associated toxic shock. This is a very dramatic, very profound inflammatory reactions. They vary considerably depending on the host. We do not know why one patient gets a toxic shock. We do not know why the other ones doesn't. A particular superantigen may therefore produce starkly diverse effects in different individuals. And Hippocrates once said, inflammation, if limited, this is before Christ, is a prerequisite for survival. But too much is too much. Now, when they invented the word transverse myelitis many years before I was here, they already thought about Jorens, because the T means T lymphocytes. The R means they are receptors for glucocorticoids which may be regulated by superantigens. The A means it's an autoimmune reaction. The N means we need new studies with antibody titers against superantigen-related bacteria. The S means Streptococcus and Staphylococcus as the two important bacteria. The V means V beta, a very specific uses in the T lymphocytes. The E means exacerbations of patients with acute demyelination, MS for instance, and chronic might be related to superantigens. The R means receptor of the T cell. The S means the shock of toxic shock. And the E means superantigens are called exo and enterotoxin. And myelitis, the M is MHC2 class molecules, playing a role in transplantation, but also in acute demyelination. Yes to superantigens. The E is epidemiology. The L is Listeria and Streptococcus pneumonia, which cause otitis and then encephalitis. The E is inflammation. The T is there are 3 criteria for superantigen. E interleukins play a role. And the S is the second International Transverse Myelitis Symposium, of which I was so glad to participate.
Okay, that's great. I know that many of us are going to have questions, but we do have to stay on course. So I'm going to